Now that we have understood the classification and mechanism of NSAIDs, let us move to a very important and high yield area: individual groups of NSAIDs, their key characteristics, and their specific uses with rationale. This is extremely important for clinical application because not all NSAIDs are the same, and choosing the right drug depends on understanding these differences. Let us begin with the first group, salicylates, with aspirin as the prototype. Aspirin is unique among NSAIDs because it irreversibly inhibits the cyclooxygenase enzyme. This irreversible inhibition is especially important in platelets, which cannot synthesize new enzymes. As a result, aspirin produces a long-lasting antiplatelet effect that persists for 7 to 10 days. This makes aspirin the drug of choice for prevention of myocardial infarction and stroke. However, because it strongly inhibits COX-1, it also reduces gastric protective prostaglandins, leading to a higher risk of gastritis and ulcers. Another important point is that aspirin should not be given to children due to the risk of Reyes syndrome, which can cause fatal hepatic encephalopathy. In overdose, aspirin causes salicylism, characterized by tinnitus, vomiting, and metabolic acidosis. Next, let us consider propionic acid derivatives, such as ibuprofen and naproxen. These drugs are among the most commonly used NSAIDs because they have a good balance between efficacy and safety. They are reversible COX inhibitors and have relatively lower gastrointestinal toxicity compared to aspirin. Ibuprofen is widely used for mild to moderate pain, fever, and inflammation. Naproxen has a longer duration of action and is often preferred in chronic conditions like arthritis. An important clinical point is that naproxen is considered to have a relatively lower cardiovascular risk compared to other NSAIDs, making it a safer option in patients with cardiovascular concerns. Now coming to acetic acid derivatives such as diclofenac and indomethacin, these are more potent anti-inflammatory agents. Diclofenac is widely used in post-operative pain and inflammatory conditions due to its strong anti-inflammatory action. However, it is associated with higher risk of hepatotoxicity and cardiovascular events. Indomethacin is one of the most potent NSAIDs and has a special use in the closure of patent ductus arteriosus. The rationale is that prostaglandins maintain the patency of the ductus arteriosus, and indomethacin inhibits their synthesis, leading to closure. However, indomethacin has significant adverse effects, including gastrointestinal irritation and central nervous system effects like headache and confusion, so its use is limited. Next, we have oxycams, such as piroxicam and meloxicam. These drugs have a long half-life, allowing once daily dosing, which improves patient compliance. Meloxicam has some degree of COX-2 selectivity, making it relatively safer for the gastrointestinal tract compared to non-selective NSAIDs. These drugs are mainly used in chronic inflammatory conditions such as rheumatoid arthritis and osteoarthritis, where long duration of action is beneficial. Fenamides, such as mefenamic acid, are particularly useful in dysmenorrhea. The reason is that they reduce prostaglandin levels in the uterus, thereby decreasing uterine contractions and relieving pain. However, they are not commonly used for long-term therapy due to gastrointestinal side effects. Now let us move to the selective COX-2 inhibitors, also known as COXIBs, such as Celecoxib and Etorecoxib. These drugs were developed to reduce gastrointestinal toxicity. Since they selectively inhibit COX-2, they spare COX-1, preserving gastric mucosal protection. Therefore, they are particularly useful in patients who are at high risk of gastrointestinal complications, such as elderly patients or those taking steroids. However, the major disadvantage is increased cardiovascular risk. By reducing prostacyclin without affecting thromboxane, they create a prothrombotic state, increasing the risk of myocardial infarction and stroke. Therefore, they should be avoided in patients with cardiovascular disease. Now let us discuss some special NSAIDs. Paracetamol, although often grouped with NSAIDs, has very weak anti-inflammatory action. It primarily acts centrally and is mainly used as an analgesic and antipyretic. It has minimal gastrointestinal and platelet effects, making it safer in patients with gastric issues. However, in overdose, it can cause severe hepatotoxicity. Ketorolac is another important drug known for its very strong analgesic effect. It is often used in post-operative pain and is comparable to opioids in efficacy. However, due to its high risk of gastrointestinal and renal toxicity, it should be used only for short durations. Now let us integrate uses with rationale. NSAIDs are used in pain because prostaglandins sensitize nociceptors. They are used in inflammatory conditions because prostaglandins mediate vasodilation and edema. they reduce fever by lowering the hypothalamic set point. In dysmenorrhea, they reduce uterine prostaglandins. In migraine, they reduce neurogenic inflammation. In gout, they suppress prostaglandin-mediated inflammation. In colicky pain, they reduce smooth muscle spasm. Aspirin is used for cardioprotection due to its antiplatelet effect. Indomethacin is used for closure of patent ductus arteriosus. Ketorolac is used for severe post-operative pain due to its potent analgesic action. So the key point to remember is that each NSAID has a unique profile, and the choice of drug depends on balancing efficacy with safety in each patient. Understanding these differences allows us to use NSAID rationally and effectively. Thank you.